In episode 30, we're going to look at BBH. Now, BBH was an attempted murder charge for which Letby was found not guilty. But the purpose of this podcast is to demonstrate just how awful the care in this place was. We'll start off with the mother's statement, and the mother's statement says that BBH was born in September 2015 and had a healthy pregnancy. The only complication being that she was a type 1 diabetic. That is a very serious complication, apart from the risks to the mother herself of the complications of diabetes. And remember, the type 1 diabetes is the one where people can't make their own insulin. They have to take insulin. The risks to them are greatly increased in pregnancy, but also they're at a higher risk of preeclampsia, which is the blood pressure that goes up with pregnancy, preterm labour, caesarean section, fetal problems, birth defects, stillbirths. All of these are risky pregnancies. And to be honest, I'd never attended to one that didn't have some kind of complication coming up. That's a big red flag there. And she was admitted to medical care in September 2015 as her blood sugars kept dropping. That was her own blood sugars. Once their staff talked about the possibility of inducing the labour, so that's bringing it on earlier, she went to hospital and had the view she was not to give birth for a few weeks. She was then visited by a consultant and told that on September 22nd, the birth was to take place. There was a complication in that BBH would be a couple of weeks premature. There was also no beds available in a neonatal unit or in any other equivalent centre, even as far away as Birmingham. As preparations were made for the mum to give birth, a bed in the neonatal unit became available. The birth took place and BBH was absolutely fine and might not even need to go to the neonatal unit. That's what the mother was told. Both parents were allowed to hold the baby girl, but she became pale and began grunting. BBH was taken to the neonatal unit for oxygen as she was struggling to breathe. The mother says BBH was put on CPAP to assist her breathing. She's on pressurised breathing, but she mightn't have to go to the neonatal unit. The parents tried to go to the neonatal unit, but were informed that BBH was placed on a ventilator. We can just see the escalation. You know, not every baby who's on ventilation ends up on a ventilator. They were quite annoyed they had not been informed about this. No consent, just far ahead. And staff said they had been busy and no one had been around to inform them. This is the standard of this hospital. After several x-rays, I wanted to get consent for that. It was established that BBH had suffered a suspected lung puncture. The repairs were made with her but could not pick her up. The following morning, nursing staff said the mum had to come to the unit straight away and bring her husband too. BBH was being treated with lots of medical people surrounding her. They were resuscitating BBH. The mum was told to sit with BBH and hold her hand. The staff successfully brought BBH back. The staff could not explain her cardiac collapse. BBH was doing really well that day. The parents had just gone to bed when staff knocked on the door. They said BBH was not responding. Parents were met with almost an identical scene, with BBH surrounded by medical staff. Fortunately, this collapse did not last as long. This is the second collapse of the baby. Following this, BBH was transferred to Arrow Park Hospital on September 27th. The staff there removed and replaced the ventilator. They checked BBH over the brain scan, fortunately showing no term damage. BBH improved dramatically as soon as she was at Arrow Park, and within 24 hours she was off a ventilator and back onto CPAP 24 hours later, she was off CPAT and made a dramatic improvement. She was taken back to the Countess, and the only difficulty at that point was putting her to feed. BBH stayed at the Countess Chest Hospital until October 9th, when she was discharged earlier than normal for a baby outpatient. There was no long-term complications whatsoever, thank God, for BBH. We have some more information here that the prosecutor, she had an uneventful birth. No, she had an emergency cesarean section, which is not an uneventful birth. And we have an unnamed nurse, and the unnamed nurse, she apologised to the family, the parents of BBH, for not informing them sooner about her daughter's condition. Yeah, there's a typical kind of story from this place. BBD comes to mind, BBC comes to mind, all good signs, and then they're really not all good signs. And then we have Alison Ventris again, the junior doctor, who's not really at fault for any of this stuff, giving evidence. And she was informed that BBH had breathing difficulties, poor chest movements, and poor colour. BBH oxygen levels plummeted shortly after her arrival, and she called for a consultant to assist. More desaturations followed as BBH received a series of invasive needle treatments for a tension pneumothorax, an emergency situation where air accumulates between the chest wall and the lung, which causes it to collapse. There is a difference between a pneumothorax and a tension pneumothorax. A tension pneumothorax is when air gets into the space between the lungs and the tissue covering the lungs, called the pleura. There's a gap there. There's always a gap, and that gap is full of lubricant which allows the lungs to expand against the chest wall. That little gap is always there. But it fills with air, that a pneumothorax. Tension pneumothorax is when it continues to fill with air. And when it continues to fill with air, it starts to compress the lung underneath it more. It starts to push the heart over to the opposite direction, and it's a much more serious problem. Most tension pneumothoraxes in preterm neonates are because of the ventilation and high peak inspiratory pressures, high positive end pressures, long duration, premature birth, low birth weight, surfactant deficiency, respiratory distress syndrome, the usual things. And we know that this baby has respiratory distress syndrome. We would need to know what all of those readings were, but Letby was not found guilty of anything here, or why they even brought the case. It is very difficult for me to know. She goes on the following night shift, she noticed a cluster of desaturations in a 2-hour period. She said she later found out a chest drain that was a tube put in to this pneumothorax area to drain the air and equalise the pressure from the outside to the inside, that the lung could expand within a suboptimal position, and it had almost fallen out. Oh yeah. Dr. Ventris noted at 1 a.m. on September 26th that a combination of BBH's readings, needing more respiratory support, and a drop in her blood pressure led her to think that she may have had another tension pneumothorax. This is that 1 a.m. That led her to think that she may have had another tension pneumothorax. But there doesn't seem to be any action taken here, because at 3:40 a.m., which is 2.5 hours later, she received a crash call from the nurses to the neonatal unit. BBH had desaturated to levels of real concern, and her heart rate had fallen below 100 beats a minute. She said she was informed that no trigger was identified, but she had identified one herself 2 hours earlier. Chest compression commenced at 3:26, and her oxygen levels and heart rate continued to drop, the court was told. BBH was given several doses of adrenaline before compression stopped at 3:46 and the heart rate rose to a safe level. Dr. Ventris said, we followed the cardiac arrest protocol and she recovered. But we never found out the reason why she got into that state. Well, it's partly the stress syndrome, and she has a pneumothorax. She's just been born. I don't know. I mean, then we get Benjamin Myers. Do you agree there are numerous reasons why a baby on a chest strain may desaturate? Yes, said the doctor. Mr. Myers, if you look at the days leading up to the event of the 26th, over those days there have been multiple desaturations with this little girl. Dr. Ventris, yes. Mr. Myers went on, indeed, in the hours leading up to the event we are looking at, there were a series of desaturations over the night, weren't there? Yes, repeated Dr. Ventris. She also agreed baby H had been suffering for a prolonged period of time from tension pneumothorax, and the reality is that she had been through an awful lot of medical activity. Dr. Ventris conceded it was conceivable that babies under such intervention could suffer quite significant collapses. We just see here how the purpose of all of this prosecution evidence is to find fault where no fault exists, or to find complications or suspicions where no suspicions exist. This is a baby, 34 weeks, late preterm, diabetic mother, RDS, on ventilator intubation, on CPAP, has now a tension pneumothorax. That's an ongoing pneumothorax. She's desaturating for hours beforehand, and they're still trying to look for reasons why Letby could be involved in a collapse. That's vindictive. That's not an honest prosecution. And then pop-up prosecutor, he comes in and he says, you confirm desaturations are not uncommon, but babies experiencing the sort of problems BBH are experiencing are arrests as common as desaturations. Dr. Venter said arrests are not all that common. I'm not saying they're impossible, but they are not common. Well, Mr. Pop-up prosecutor, if you don't deal with the problems that you're facing and de-escalate them, an arrest will eventually follow anything you get, including a cut finger that keeps bleeding. We go to an unnamed shift leader who said the court heard that 13 children were in the unit in the early hours of September 26, with 4 nurses allocated to their care. 13 babies, not children, 13 babies, 4 nurses, and one of them as sick as this baby. This is what this hospital was doing to the local population throughout the time that they're now crucifying Lucy Letby for. That is unforgivable. Letby was tasked with looking after a sole baby, baby H, in intensive care, nursery 1. That's because she was the only one trained in intensive care. The evening's nurse shift leader, who cannot be identified for legal reasons, I wouldn't blame her, agreed with Mr. Myers that caring one-to-one for a baby such as baby H was potentially quite a demanding job for a nurse of Letby's experience. But she added, Lucy was qualified in specialist neonatal nursing at the time and was very competent. She was not a totally inexperienced nurse, and I would trust that she would ask me if she had any problems. I mean, there's 12 other babies there. Why is she going to ask you? And then Myers' cross-examination. Was there an issue with Lucy Letby being relatively junior compared to others, and some debate about her going into nursery room 1 to look after the poorly babies? Sometimes yes, was a reply, and sometimes a bit of under the surface dispute about that. Is that correct? And the witness said yes. There's a bit of background. I don't know what it means. And then we get to the hero of the hour, Ravi Jairam. Consultant paediatrician Dr. Ravi Jairam is now in the witness box. He is recalling the events of the 26th of September. Dr. Jairam was called by a junior colleague, Dr. Ventris, in the early hours as medics were having trouble with baby H. Baby H needed numerous procedures to drain air from her chest, after she had suffered a pneumothorax. This is where air leaks into the space between the lungs and the chest wall. Dr. J. Ram is explaining the condition and how it is diagnosed and treated. The jury are shown X-rays of BPH, which show excess air in the chest cavity, and the jury will really have been able to read them. BPH had a chest drain and 2 needles to drain air in a bid to treat this. So 3 drains. Now, it's okay to use butterfly needles. These are the little short needles. You can use butterfly needles in an emergency, and you can use them even up to 24 hours. But if you're needing 3 of them, you haven't got your main drain in right. Dr. J. Ram is currently describing in detail the process of inserting the chest. X-rays taken in the early hours of the morning of the 25th showed that BPH's lungs had reinflated after the procedures. Lots of black air present on the previous X-rays in the chest area had disappeared. But this is a tension pneumothorax. This could reappear at any time. Ben Myers KC defending is now questioning the consultant and asks whether the active fitting of a chest drain can cause stress to a baby. He says it can raise heart rates. You can imagine someone sticking a tube into your chest wall. You think it's going to raise your heart rate or going to cause you complications? Of course it is. Mr. Myers is asking whether a drain could come into contact with internal structures like the heart. Dr. J. says he has never seen this happen. Of course he says he's never seen it happen. But has it happened? To put things into perspective, the incidence, that the number of times that happens, the incidence of type 1 diabetes in the UK, in the peak age group, that's 10 to 14 years of age, is 0.04%. Believe it or not. Now, nearly everybody knows someone who has type 1 diabetes. But that's the incidence, 0.04%. What's the incidence of heart damage from chest drains going into preterm neonates? Well, the frequency of serious complications are between 5 and 10%. 100 times, 200 times more common than you would see a type 1 diabetic. And the incidence of bleeding into the heart or heart damage from it is 1 to 3%. Again, magnitudes bigger than the incidence of type 1 diabetes in these particular babies. But Dr. J. Ram's never seen that happen. He says anatomically he can't see it, as the heart is surrounded by the lungs and the lungs would have to be punctured. No, the lungs don't have to be punctured. They can be pushed over and displace the heart. Mr. Myers puts it to Dr. J. Ram that due to improvements in medicine, pneumothorax is less common. He said, generally speaking, doctors now are likely to have less practice on chest drains. And Dr. J. Ram says he wouldn't disagree with that. Depends what unit they're working on now. And he says that is why such treatments are more often carried out by consultants, as they're from a generation when they were more common. Dr. J. Ram is an expert on these things. Mr. Myers is asking Dr. J. Ram where the optimum space is to insert a chest drain. He puts it to the consultant that the 5th intercostal space, that's if you count down the little spaces in between your ribs, that's the 5th one down, is the best area and is standard. And Jerram says it doesn't matter as long as it is going to drain air. Dr. Jerram eventually agrees that ideally the 5th intercostal space is where the drain should be fitted. Discussion in court is currently centered on the use of different drains. There are different types of drain you can put in, but they all basically are trying to do the same thing. BPH had what's called a pigtail drain fitted first by Dr. Ventus. That's the proper one to fit. And then Dr. J. Ram fitted a straight drain a short time later. Dr. J. Ram concedes that it would have been easier to fit a second pigtail drain, but there were none available in an intensive care unit. the ideal instrument to deal with pneumothorax, which is common in people who are on ventilators, positive pressure ventilation, particularly by people who are not particularly good at using it, but they only had one. Mr. Myers shows the jury an X-ray of the two drains in BBH. The first established was in the ideal fifth intercostal space. The second, fitted by Dr. Jairam, was not in the fifth intercostal space. His notes written at the time say it is. Dr. Jairam agrees it's clearly not in there, but says the drain is still in a good position. Why do we have ideal positions which we can just shift to good positions when we want to? He says it is in the pleural cavity, and that is working. Mr. Myers is repeatedly putting it to the consultant that the chest drain is in the wrong place. No, it's in the pleural cavity. You're focusing on process rather than outcome. This is Jairam. It needs to be put in. It isn't going to have any real effect on the heart function. How true is that? Well, the reason that people decide it, probably after years of screwing up, but decide that the fifth intercostal space is considered the ideal location for a chest drain insertion. It's because of where it is. It's a safe distance from vital structures. It's far enough away that you won't cause direct injury to the heart or the lungs or a major blood vessel or a nerve. It's also easy to get at. It's the easiest space to find. That makes the process straightforward. And it provides the optimal drainage because of its location. Gravity will help to force the air out. It has a much lower chance of kinking or twisting in place when you put it in the fifth intercostal space. And I did a lot of these in adults with penetrating injuries. It's just much easier and much more predictable. But if you put it in another place, you increase the risk of cardiac injury, particularly if you put it in the second or the third space. Lung injury if you put it in the sixth or the seventh space. Blood vessel injury if you put it in the first or second space. And nerve damage if you put it in the third or fourth space. There are reasons why you don't do this. And just say, oh, it doesn't matter because it's working. Okay, it works. What happens when it works? He's using needles. And if the lung suddenly reinflates, those needles are going to penetrate into the lung tissue itself. This is all pretty, well, they say suboptimal. It's just terrible, you know. Myers carries on repeatedly putting this to him, and he keeps arguing, no, it doesn't matter. And Mr. Myers puts it to the medic that if the tip of the drain was close to the heart, it could cause bradycardia if it moved. It could, says Dr. Jairam. Mr. Myers says if the baby moves or is handled with a breeze, these can all cause the drain to move. And Dr. Jairam agrees. Again, it moves much less when you put it in the fifth space, but disputes the inference of the question. He says any movements would be minimal. But remember, Dr. Bendis has said that the drain had almost fallen out. Mr. Myers put it to Dr. Jairam that he inserted the chest drain in a suboptimal position and that this contributed to child HSD saturations in the hours and days that follow. And the consultant rejects this. Of course he does. He says the drain was not in the wrong place. The drain was in the wrong place in terms of where doctors are advised to put it. And then he accuses Mr. Myers of being focused on process over outcomes. But he doesn't say that following that process improves the outcomes. And I will just do the cross-examination of Dr. Gibbs because it's the same story, stable baby story. Myers puts it to Gibbs that against the background of BBH and everything that she's been through, the insertion of multiple chest drains and all the rest of it, It was no surprise that she had collapsed on September 26th. Dr. Gibbs said he was surprised because she had been stable. Yeah, she was stable. The judge asked Mr. Myers to clarify whether he is suggesting BBH collapse came as a consequence of the procedures, chest drains, intubation, etc. And Myers says yes. He says, with particular reference to the drain fitting by Dr. Jairam, that he wants the jury to look where it goes and what it could have done. Well said, Myers. Give you that much. Then Myers has a wee chat with Dr. Bowen, and she agreed that there had been delays in intubating the baby, and there had been delays in giving surfactant of a new. And she also agreed that that meant that when the baby was ventilated, the increased air pressure needed had the effect of worsening her pneumothorax. She agreed that all of these delays and all this faffing about actually caused the pneumothorax and caused the child to be ill and caused the complications that came from that. But again, Dr. Bowen insisted the staff were dealing with an emergency. Yeah, well, they weren't dealing with it very well, were they? And that there was no option. It was a life-saving measure. Well, the option was to do it properly. She said that the butterfly needle left inside the baby's chest might have punctured the lung tissue and contributed to the ongoing pneumothorax. She's just arguing with herself. And then she says something really strange. She says she rejects Mr. Myers' suggestion that the explanation for baby H's two mystery collapses might have been the cumulative effect of a series of procedures that she'd been through. The baby is desperately ill. She could have a cardiac arrest or a collapse at any time. But she's rejecting all that. She said, a baby will desaturate as a result of an event, but it's not cumulative. And it certainly doesn't cause a cardiac arrest. Let's follow that logic then. It has a desaturation as a result of an event. The desaturation leads to the build-up of acid in the blood, this metabolic acidosis. And then it has another one, which leads to a bigger build-up of acid. And then another one, and a bigger build-up of acid. Then it has a bit of oxidative stress, choked in periods of more under perfusion, all of which are cumulative. What will happen at the end of all that is the blood will become acidic, the heart can't beat. It does cause cardiac arrest. Cardiac arrest does follow cumulative events. I don't know what she's talking about. And then she goes on, Dr. Bowen also rejected the barrister's suggestion that the pneumothoraces meant BBH would have fared better if she'd been moved earlier to the tertiary unit, such as Arrow Park. To which the lovely Dr. Bowen says, no, because they can occur spontaneously, which is irrelevant to this situation because we already know it occurred because of the overpressurization. And that would mean every baby would need to be born in a tertiary unit, which isn't practical. Oh, God. And then Derry Evans, we'll ignore him in this one because he doesn't actually say anything of any value. Well, he doesn't ever really say anything of any value. But then we go to Professor Owens, which we get into an interesting little tussle here. And the consultant paediatric radiologist, Professor Owens, is first up at the witness box this morning, and he's given expert evidence on CT scans, X-rays, and other images in the case, even though there aren't any others. There's only X-rays for. Dr. Arthurs is now going over the X-ray for BBH, which shows the drains. Dr. Arthur notes that the position of the drains have moved, but he says that the precise location isn't really critical, as it's having the desired effect if it's draining the pneumothorax, essentially supporting what Dr. Jairam has previously said here. But we have to remember now that Dr. Arthurs is a radiologist. He's not a pediatrician, and he doesn't work in emergency medicine. He doesn't see what goes wrong when the chest drains move and when they come out or the needles go into the lungs. We've already established that leaving needles in lungs, particularly in these tiny babies, can cause terrible problems, right? Myers goes on and he says, he's asking Dr. Arthurs about BBH and the positioning of her chest drains. Myers asks if he is aware of guidelines where chest drains should be inserted in terms of the intercostal space. And Dr. Arthurs says that the guidance to which Mr. Myers is referring refers to where they go in terms of the chest wall, not where they are inside the chest. Does that mean then that if you put a chest drain properly into the fifth intercostal space, it's suddenly going to at the seventh or eighth intercostal space? No, it doesn't. That sentence makes no sense. You put it into the fifth because you can't control where it goes when you put it in the fifth. Dr. Arthur accepts that a neonatologist is better placed to comment on positioning of drains and clinical impacts. Dr. Arthurs accepts that a radiologist shouldn't be given expert evidence on the insertion of chest drains in babies. We can see this was just a mess from start to finish. Not untypical of this unit. And I'll leave the link for you to read the rest of it. It's just sad. And in the next episode, we'll get on to the case of baby I. Remember, Letby, her verdict of not guilty for baby H and no verdict for both of the alleged attempted murder. I think, if anything, that shows the probable difference in the outcomes of this. Had there been a proper defence that would have shown these people up for what they were, storytellers. In the next episode, we'll move on to the case of baby I, and that's a murder for which Letby was found guilty. I'll see you in the next episode. Bye.